Thank you, Nancy. Thank you also for inviting me. Nancy mentioned I'm her new dean, and new is the operative word. I've halfway through my second month. I've sent an entire closet full of red ties to the Goodwill. I only have 2 blue and gold ones. I'm wearing one of them. I've been to my first football game against UCLA. We lost 45-10. I'm learning the rules of how to play the game. But I'm also trying to figure out what are the healthy competitive spirits between campuses of the University of California and which ones are unhealthy and that we need to bridge. I think it would be really useful if UCSF developed a football team. Because that would give us a healthy competitiveness and help distract us from some unhealthy competitiveness. I am incredibly excited and committed to what has already been laid out to you as challenges for both of our campuses. And I do think we have, the complementarity we have between our 2 campuses overwhelms by far the areas in which we might feel more directly competitive, and that creates huge opportunities. We are talking today about implementation science, and a number of people have already said part of what I was going to say. But I thought I would just start with an even simpler version of what Ralph showed us, and that's just asking the question of what is it that we're talking about. So when I said to myself, what is it that we do in super simple terms without Ralph's complicated diagram, we develop new tools and interventions. We decide which of them we're going to actually produce. I'm thinking more like the private sector here. We identify the best ways to produce them, and then we figure out how to do so efficiently and effectively at scale. And it's clear to me that the one that's in red down there is not what we mean by implementation science. And I think various people might differ as to exactly where the boundaries of implementation science go across the other 3. And then I thought to myself, well, what kind of science do people call some of the other stuff? And we saw a bunch of disciplines and other things on that very helpful 3-ring slide that Ralph showed. But the red part is the R&D, and I think we're all pretty clear that R&D is not implementation science. But does it include the decision sciences that go into figuring out what is it that we should be implementing? The things that went into deciding whether PEPFAR was going to scale up PMTCT and male circumcision or something else. Lots of different names for it, but operations research, this idea that if we're in the business of producing mozzarella, are we going to produce mozzarella in every single one of our 10 delis? Or are we going to produce it centrally in Los Angeles and distribute it to the 10 delis in LA? Figuring out the mechanics of what is the most efficient way to produce a good, a service, or whatever, that's in that sort of realm of operations research. And then there's the question of, once we figured out what we want to do, and we figured out the mechanics of how we want to do it, we've got the question of, then how do we actually make that happen at scale? And that includes a lot of the things, and Ralph touched on them, behavior change of politicians, of providers, of clinics, of health systems, all kinds of things. But to do that with fidelity, at scale, and I don't know exactly what to call that, but it certainly is a mixture of advocacy and management science. And one of the things that I think was a challenge for us is we are a bit in a soup of nomenclature. You know, when we talk about delivery science or implementation science, are we talking about the same thing that the private sector does with mozzarella, or are we talking about something really different? Or maybe it's for the public sector because we don't have profit to guide us, and therefore it's the science of implementation in the non-private sector. But in that case, isn't what we do very similar to what they need to do in agriculture and agricultural extension and things like that? So it is, I'll be very interested throughout this day to see implicitly what comes out of these discussions in terms of what it is that we consider our scope. I'm going to just say a few more words, mostly about the top of that, which is once we've not only got the tools, but decided which of those tools and interventions we want to scale up, and even decided that, you know, we're going to do annual CD4s or twice a year CD4s, or we're not going to do viral load, or we are. We're going to have provider treatment initiated by a nurse or by a doctor, or whatever it is that we've decided is the model we're going to implement. then what do we need to do to actually scale it out massively? And I think that what you just heard from Eric was an excellent example of the little circles at the bottom of Ralph's slide, which showed this iterative improvement. If we had the PEPFAR that we could have had today, if we had scaled up the original models exactly as they were, I don't know what the number would be, but we'd probably be covering a quarter of the people that they're currently covering. So there have been these continuous improvements. We started off with largely non-generic drugs. We started off with all the many things that Eric mentioned, but that included models of how care is done at the facility level. It included all kinds of iterative improvements. So the program has, in fact, been doing a lot, a huge amount, to improve the efficiency and effectiveness of what it's been doing with the same resources. So my key takeaway for today, I thought I might as well start with the end takeaway, is that we've made a lot of progress in the research space into HIV/AIDS programmatic efficiency and effectiveness. We know a lot more today than we did 10 years ago about how to do it. And we've done that in terms of research, mostly with big, complex, one-off research studies. Now, in addition to that, we've had a huge amount of learning of just people on the ground doing stuff, right? And people learning from each other. And my takeaway is that we need now to shift into a new mode. And that new mode goes in one of two directions, and which of those two directions we go in will depend on what it is we're trying to do. One of them is that you can't look at Tanzania and say, we've improved male circumcision coverage in Tanzania, and have that be useful for the national circumcision coordinator in the country. That person has to have much more granular information, because the only way he or she can improve the performance of the national male circumcision program is to know which districts are performing and which ones are not, figure out what's going well in the good ones, and make sure that that gets fixed in the bad ones. Now, sometimes we're lucky, and we don't have to have granular data and be able to manage down to the level of where the stuff actually happens. Sometimes we can just create the right incentives and it'll happen by itself. And that's the magic of the profit motive in much of the world that we live in. Unfortunately, it's not usually applicable to our world unless we can create the incentives that substitute for that market pressure. And here is an example of the former. It's an example from the Avahan program, a big HIV prevention program in India that many of you are probably familiar with. And this is sophisticated management at the level of sex worker peer educators, most of whom are illiterate, in brothels and other places in 4 states, mostly in India. And here is the mapping process. And then here is the sheet on which the sex worker sticks her colored stickers for each of the people, of the women that she's responsible for, to show what services they've gotten. That stuff can be aggregated up, and you have a management information system which starts with an illiterate peer educator and colored stickers, but enables the folks managing the program in Delhi to go Delhi to the state coordinator, coordinating agency, to the district coordinator, coordinating NGO, to the community-based organization that is actually supporting the peer educator to reach the individual sex worker. You have a management system that applies modern management principles to something where many people would have thought impossible, and which led to this extraordinary scale-up of this program across 4 of the biggest states in India. I mean, the first time I went to Andhra Pradesh and realized that it was 80 million people, and I was in Mexico, which was a big country, at 110. Now, this is an example, which is a little bit further from HIV, but it made me think of when I was a kid, and how, living in Colorado, and how there'd been this enormous decline in the number of coyotes. And back then, I think it was $10, but it might have been less than that, but the government was paying a bounty. And I thought it was the tail, but in this most recent program in Utah, it was scalp and lower jaw. You get now $50 in Utah for every scalp and jaw you bring. And it doesn't really matter how it's managed or organized, or whether this guy performs better than the other guy, because frankly, if what you care about is reducing the number of coyotes in Utah, and you set up the right incentive structure, it will just happen. Now, some things that we do may be amenable to setting targets that that you can measure like that, and rewarding people for doing them. Now, you know, we might prefer to have 24-year-old foreskins removed than 12-year-old foreskins removed, and we might, you know, it might be more difficult to come up with the incentives to actually incentivize the right foreskins, but it may well be that we can set up programs that don't have to go to every single site that is circumcising and figure out how to improve their efficiency if we can get the incentives right. But in health, that's unusual, right? Usually, we need to understand how well the thing that's doing the thing is performing. So if we take the example that Eric was talking about, antiretroviral therapy, when I first started talking about this in Mexico, and I was talking about the fact that we were dramatically underperforming because, like Brazil, we had created universal access. Unlike Brazil, we hadn't seen mortality fall. So something was really bad if we were spending huge amounts of money buying antiretrovirals and distributing them and starting people on treatment, and yet we weren't seeing the expected reductions in mortality. And after I gave the talk, a guy came up to me who was at far from the capital in a clinic where he'd gone to, having trained at the National Institute of the equivalent of internal medicine. And he said to me, Steph, you know, you're understating the case. I left what is arguably the best HIV clinic in the country and went to this clinic where I'm working now, and I discovered that 30% of our patients were virally suppressed. So it's really important to know how the clinic is performing. It's really difficult if you're at the national level to actually get to the kind of performance standards that Eric wants to in either efficiency, as in results per dollar, or in effectiveness, as in people effectively having their lives extended. Siri never understands me either. But we have to have data at the clinic level. And fortunately, the world is changing. So we've seen lots of advances. I'm going to show some of Eric's slides. Are these Eric's slides? These are partly Eric's slides. These are certainly slides from Eric's program. And what you see here is the cost in 5 different countries of antiretroviral treatment. And first of all, just wow. I mean, you know, these are data down around $200 per person per year. Now, that's not fully loaded. That's just at the facility level, but wow. And when we started to look at this, 10 years ago, in prevention costs, we were seeing 2 orders of magnitude of difference from one clinic to another. I mean, just huge differences in efficiency. And now, you know, I mean, when I showed this to Bill Gates, he said, well, you've still got 2-fold differences here, you know? What's wrong with you? And I'm like, yeah, but we had 100-fold differences, so this is damn good. And even better, there's actually, you know, breakdowns of what do those costs come from. And if you look now at antiretrovirals, you say to yourself, wow, well, does that make sense to have that much difference in antiretroviral costs? Well, it turns out almost all of the differences that you see in antiretroviral costs among the 4 lower income countries, not South Africa on the right, are due to what is the mix of drugs. So actually approximately equal efficiency in procurement. Huge, huge advances, and that's both Global Fund and PEPFAR, huge advances. South Africa, this was before they negotiated a 40% reduction in their new procurement of drugs. So even South Africa, which is more similar to Zambia in its mix of drugs, is now far better than is shown there. Whoa, that really didn't work, did it? God, switch to a Mac. It's what happens when you bring a slide from the Gates Foundation, show it on a Mac. You get sabotaged. So this is just a different representation of the declining costs of antiretroviral treatment. And if you look at the bottom, it's sort of progressively, what happens, well, you get a big reduction in cost just associated with scale. If you look clinic to clinic to clinic, you can explain a whole bunch of the difference in cost from clinic to clinic. The clinics that treat a lot of people do it for less money. And the clinics that have been around for a couple of years do it for less money. Turns out scale and experience are good things. Well, experience we're just going to get naturally because clinics are going to be around. And scale may tell us something about the relative pros and cons of having lots of smaller clinics versus smaller big clinics. And it will tell us something about what will happen to our costs as we reach further into rural areas with smaller clinics that can't achieve, by virtue of their catchment area, the same scale levels. We also are learning about what are the determinants of retention, which I would argue is probably the vast majority of what explains the differences in Mexican clinics with respect to viral suppression. Those clinics that are able to adhere, I mean, obviously we also had problems in clinics and prescribing behavior and other things, but most of the difference is because some clinics achieve high levels of adherence and others don't. And while we see that also, I mean, Rwanda achieves better adherence nationally than Uganda does, and right next door. But more importantly, you can see specific programs, and we can learn from the differences between specific programs and clinics and why it is that some are able to achieve better performance than others. I think a perfect example for me is when I see that the national adherence statistics, if you can believe the statistics that I see, from Rwanda are better at the national level than they are in the programs supported by Johns Hopkins and Rokai. And that's despite the fact that that program goes to every household in their cohort, it's a community-based cohort, and offers services to people. So we've got remarkable differences despite levels of effort that are inversely correlated with the performance. And so it seems to me that we need to understand much better what are the determinants of performance. And that says there, that we have a lot further to go. So obviously we're very, very far. Even though we may get close in the next few years on prevention of mother-to-child transmission, we're very, very far from having stopped this problem. And we're still having far more people getting infected than we can possibly think is appropriate or sustainable. And I'll just make one plug, and that's that one of the reasons is that we measure the wrong things. And the reason I come back to this issue of measuring the wrong things is because it isn't really fully a dichotomy. You know, either you manage things with data down to the level of the delivery unit, or you create the right incentives. Most commonly, it's going to be a combination of those two. And I think that one of the mistakes that we made early on was that we asked PEPFAR to do 2-7-10. This is in the years before Eric got there. But what we said is we want people taking drugs. We want 2 million people taking drugs in the first phase of PEPFAR. Well, if people taking drugs is well correlated with people staying alive who otherwise would have died, that's okay. And it is reasonably well correlated, but it's not well enough correlated. And Mexico proves that it's not well enough correlated. And frankly, we have great heterogeneity in Africa as well of the degree to which pushing drugs out translates into increasing life expectancy for people living with HIV. And one of the problems with just measuring how many people take drugs is, well, this is my little 5-minute model of antiretroviral coverage over time. This is 30% of the newly eligible people every year get treatment. 70% of people don't and die, okay? Now, that's terrible, right? What happens to coverage? Coverage defined as we do today, which is the proportion of people alive who are in need of treatment who are getting it, right? Well, this is what happens over time. And why does that happen over time? Because we're only covering 30% of people. It's because we're saying people receiving treatment over people eligible. But people receiving treatment accumulate, they stay alive, and people eligible die. So you've got an indicator where you accumulate the numerator and you kill the denominator. So some of the improved coverage that we see in our coverage statistic, a significant amount, has to do with the fact that we keep killing the denominator. Okay? So I would argue that we shouldn't incentivize. We made a mistake in Mexico to incentivize number of people getting drugs. We should have been incentivizing something better. Now, just with respect to this indicator, a better figure is what proportion of people are dying without treatment and what proportion of people, which is of the people who this year should start treatment, what proportion do and what proportion die, right? That's a very different number over time. The other thing is that we can think about, well, we would like to know how many people are effectively virally suppressed. I don't care how many people are taking drugs because the 70% of people at that clinic in the state I won't mention who were not virally suppressed, they're not getting the benefit of the money that we're spending. We're getting 30% of the benefit there. And we could easily be doing 80 or 90% of the benefit. So we want to know things like this. We want to know the number of people who are virally suppressed, and I'm very encouraged by the fact that we're going to have close to point-of-care viral loads very soon. So I probably have to stop talking. But in other areas, I'll just stop with this slide. In other areas, we've been really good at using local data to drive improvements in performance. And this is policing data. But what people have done in police forces by saying, you know something? Crime is not distributed homogeneously in Baltimore. And if we don't put the police where the crime is, the likelihood that we're going to really address the problem is going to be low. Well, one of the really interesting things that Mark Dybel, Eric's predecessor at PEPFAR, now the head of the Global Fund, is doing is saying, let's look at that heterogeneity in countries with respect to, for example, malaria incidents in Kenya, which turns out to be enormously driven by a very small part of Kenya, right? Or HIV incidents, which even in generalized epidemics is far from homogeneously distributed. And so I'll just leave you with this, this concept that we now need to go the next step of going from where we are right now with the money that we have and what Eric and the Global Fund and countries have accomplished. And I can't mention countries without saying, you know, it's easy to sit in this country and think that everything that's been accomplished is thanks to PEPFAR and the Global Fund. But last year, for the first time, the developing countries of this world spent more on AIDS than all international global assistance put together. So the extraordinary increase we saw over the last 15 years in global funding for AIDS was more than matched by an increase in domestic funding for AIDS. But we're not going to be able, we have not sustained. The last 3 years we've seen a plateauing. So we need to get as much as we possibly can of health benefit out of the money that we spend. And we're not going to do it if we don't apply modern management principles to the work that we do. Thanks very much.